Good morning, everybody. Dr. Brunson studies vaccine decision-making in the Department of Anthropology at Texas State University in San Marcos. Thank you so much for joining us. We're looking forward to hearing from both of these incredible women and then having a really robust Q&A at the end. So I will go ahead and turn it over to Dr. Karen.
Well, thank you so much, Tara, and good morning, everyone. I'm very glad to be with you. It's just virtually, and I'm here today to talk to you about reporting on the COVID-19 vaccine efforts. The first thing I'd really like to do is to thank you all. I think in general, the reporting on this pandemic and on vaccine development has been really extraordinary. And I have to say on a personal level, I've had closer interactions with journalists during these last 9 months than I've had probably during my entire career. And I would say that I've had reasonable interactions with journalists during that time. So it's not, I'm really heartened by this. I've often referred to this time as really a national and global teachable moment with respect to vaccine development and evaluation. And really, all of you are the teachers. You are really, as members of the media, in the best position to present information to the public. And so I think it's really our role and our mandate as scientists to give you the information you need to be able to have those provide that information and have those discussions. So one thing I'd like to say is that, and this is not original with me, but a day is like a week in COVID time. So I procrastinated in getting my slides ready, and I didn't have them until Friday, but clearly I didn't procrastinate enough because, you know, the news comes on a daily basis, and I think the news about Moderna vaccines, which arrived yesterday, was really quite remarkable and may even reframe some of our discussion. So what I'd like to do now is talk to you a little bit about, and I hope you can all see this. It's a little smaller in projection than I thought it might turn out, but I wanted to talk to you about some of the things that I hope you'll think about and write about and tweet about and broadcast about in the coming months. Issues that have been on our minds and that I think you're in a unique position to communicate about. So the first category is about education. So I think that as I said just a few minutes ago, this is a time where what we do in terms of vaccine development and evaluation is center stage. And people are interested, and understandably people are anxious. And I think it would really be helpful if journalists could really provide some background information. One basic thing is to talk about how we measure vaccine efficacy and are differences that we see real. And of course, this was written before the Moderna data came out, and I think all of us probably understand that the Moderna data and the Pfizer-BioNTech data are virtually identical. But to educate the public that 90% and 95% with small sample sizes may not be meaningful differences. A talk about what's being assessed in these trials. Is it infection? Is it any COVID disease? Is it moderate to severe disease? So what are these trials measuring and what are they not measuring? And one of the really important things is that these trials are not assessing disease transmission. And so it's, you know, there's messaging that goes along with that. As we roll out these vaccines, just because you're vaccinated, it doesn't mean that you can stop wearing a mask, right? Because we know that these vaccines prevent COVID disease, but we don't know that they necessarily prevent you from getting infected, being asymptomatic, and giving it to your family member, your neighbor, somebody you care for. I think it would be really interesting if people would write a bit about the similarities and differences between COVID-19 efficacy trials and other vaccine efficacy trials. And in particular, one thing that I've really focused on, I know there's been a lot written about the name Operation Warp Speed and whether we like it or whether we don't like it. And regardless of how you feel about that moniker, I think it's really important for the public to understand what's gone faster just because we've had resources. In other words, we've de-risked going from phase 1 to phase 2 to phase 3 for companies. We've de-risked vaccine production because we've invested our taxpayers' money, our resources in that. So in what ways have the speed up been a function of resources and certainly not a function of cutting corners? Correlates of protection, a discussion of what they are, and we could talk about this later, but why the very good news about the two vaccines we've seen so far, the Pfizer and the Moderna vaccines, make it hard to find a correlate of protection in those trials. And then, of course, on the regulatory side, what is an EUA, an emergency use authorization, and what additional safeguards are in place in the specific FDA guidance for COVID-19 EUA. And then another thing that I thought would be really interesting to write about are ethical issues related to COVID-19 vaccine trials, follow-up, and distribution. A very hot topic right now, and that some of you I think have written about already, is how long should placebo recipients be followed in trials, and what are the scientific and ethical considerations? How do state plans, which were all submitted by the end of October, align with recommendations by national academies and the CDC with respect to prioritization? And what's being done at the local level to ensure equity and access for hard-to-reach populations? What impact do the vaccine characteristics, and we've heard a lot about that now with Pfizer and Moderna, very different cold chain requirements for those two vaccines. What impact does that have on those efforts? So that's not an exhaustive list, but it's a list of things that I hope you'll think about, and I'd certainly be glad to discuss any of them. And thanks again for having me here with you.
Thank you very much, Ruth. Those are some great ideas. I was taking notes myself on things I'm going to now write stories on. And I'm looking, I know we've already had some questions come in, and I'll ask you those when we get the Q&A. Remember, folks, that you can always send in questions that we'll be asking as we go along. Let's jump over to Dr. Brunson.
So hello, it's a pleasure to be with you today. As you can see from my slide, I'm going to be talking about communicating about vaccination in the time of COVID. So I study vaccination in my own work, but today I'm going to be drawing my comments from a report, The Public's Role in COVID-19 Vaccination, Planning Recommendations Informed by Design Thinking and the Social, Behavioral, and Communication Sciences, that was written by a working group of which I was one of the two co-leads. The report involved 23 experts in a variety of fields, including bioethics, communication, disaster preparedness, public health, vaccinology, and various social science disciplines. And the report is currently available through the Johns Hopkins Center for Health Security website, and a version of it will shortly be published in Vaccine as well. So the current context that we're in is really characterized by pandemic distress. Millions of people across the world have been or currently are infected with COVID-19, and hundreds of thousands have died. And the situation is only becoming worse with the onset of winter. At the same time, national and personal economic crises are widespread, and the world population at large is frustrated, concerned, scared, angry, and very much wanting the situation to end. So in this situation, effective, safe COVID-19 vaccines really do provide one of the best possibilities for society to return to normalcy. But as I'm going to be talking about today, the technological development and production of these vaccines is simply not enough. People need to be able to accept them for the vaccination process to work. So, and this is really the crux of the matter. Vaccine uptake itself is a complex social endeavor that requires as much, if frankly not more, effort than vaccine development. So at the current moment, there's still a small window of time to be able to conduct formative research, to build social capacity for vaccination, and to develop effective communication strategies. But that window is rapidly closing. So, and if these steps are not taken, like if this is done well, we have the potential for vaccination will be widespread and that the pandemic can end through this mechanism. If these steps are not taken, however, vaccines will very simply not be the solution that we're hoping for. So there are three recommendations that I want to pull out from the report that center on so what specifically needs to be done. And I've tailored these so that they're going to be the ones that are particularly salient, at least in my mind, for journalists. So the first of these is to communicate in meaningful ways, crowding out misinformation. So currently, there really is a lack of understanding in the public about what vaccines may look like. People are starting to understand that you may end up with multiple types of vaccines that are available, that multiple doses may be required. But this is something that still a lot of people are thinking it might be the silver bullet. And that isn't going to be the case. People are still going to need to be wearing masks after vaccination begins, potentially even after they've personally been vaccinated. And there are some things here that the public currently does not understand, or at least understand well. In addition to this, and thinking about this, the communicating during public health crises is always difficult. You're dealing with different audiences, diverse beliefs, people who are motivated or not motivated by scientific facts. What's going on currently, though, has really complicated matters further. So we're in the middle of pandemic fatigue, the economic crises, like I talked about, the politicalization that has occurred, and some really hits to public health at a national level have really complicated the situation that we're in. And at the same time, we're also living in a moment where social media use is very widespread, partially because of the pandemic situation that we're in. And within this setting, good communication, it really faces an uphill battle in a crowded communication atmosphere where misinformation is widespread. So given this current scenario, what can be done in terms of effective communication? First of all, it's very important that this idea of the quick fix is tempered, and journalists can play a key role in this. We need to be forecasting a range of vaccine possibilities, from best case scenarios to worst case scenarios, and we need to be upfront about adverse events. And how those should be reported and how they will be handled, because that is something that will happen. Along the same lines, we really need to be persisting in transparency around the vaccine technologies and especially the safety systems. Assuring that the vaccines that are the public's able to get are safe is really central to maintaining trust in this process. And so it's going to be critical that the public understand clearly, what steps have been taken to ensure the safety, the government oversight that's occurred, and particularly that this is definitely not something that is the result of political pressure. And third, we need to begin engaging communities to discern the matters that are most important of them in relation to COVID-19 vaccination and keep listening. So communities are going to have different concerns and different needs, and this is something that journalists can play a role in helping researchers and even government officials understand by doing interviews and by listening and talking to people on the ground. What are the concerns? You may have some communities where the concern is the idea that, this isn't being distributed fairly. You're going to have other communities where the concern is really going to be, is this actually safe? And so understanding what those are and being able to engage in those issues, journalists in many ways are, the best position to be able to handle both ways as you're constantly working with members of communities. So the next recommendation is to earn the public's confidence that vaccine allocation and distribution are even-handed. So thinking about this, and as you're all likely aware, that vaccine doses are very likely to be limited at first. They're going to be allocated in a particular way. The public needs to understand this, and they're going to need to understand what went into that decision making. And that's something that is largely, at least from my perspective and speaking with people, not well understood at this point. In addition, we need to be really aware that pre-existing inequalities might influence public perception about if this is fair or not. With some communities, especially communities of color, there's some long-standing distrust of government and healthcare, and this has been exacerbated recently with some other very big trust issues in terms of policing and governance. There have been disproportionate pandemic effects. Some communities have been more greatly affected than others. And we're already starting to see uneven access to testing sites. In Houston, for example, they had enough testing sites for the city, but when they were laid out geographically, there was an absolute dearth of testing sites in areas where poor people had access to them. And so all of these things are going to play into the people's ideas about fairness, and of course the politicalization of the pandemic, whether that's real or perceived, is really going to prime some further concerns about fairness. So what can be done? One thing, and this is perhaps through editorials or other means that our working group is advocating for, but definitely journalists could help with as well, is to really begin advocating for no-cost vaccines that are made available to everyone who wants them. That we're currently in a situation where if this relied on health insurance, that some of the most vulnerable populations would have no access to the vaccines. So that's something that we as a country really particularly need to start thinking about. And then when it comes to distribution, there are two sort of advocacy and avoid pieces to really argue for fairness and to avoid political trappings. But the other issue that I wanted to point out that's going to be very important for journalists to be aware of is conflating implementation with policy. So this situation actually has occurred in the past. With H1N1 vaccination, there were instances where different adjacent counties in different states implemented the allocation guidelines in different ways. It was an interpretation issue and some practicalities about how this was actually playing out. But the people living in these adjacent counties were hearing news reports and hearing from family and friends about things being done in different ways. And it really caused some consternation among different people and different groups that this wasn't being fair. And especially the white, wealthier people in the one county, that this was racially motivated. And so those are going to be particular issues that journalists need to pay attention to and be very aware of in terms of how this might play out on local levels and different reasons for that, and what's policy and what's not. And so truly, what are those differences without leading into questions about unfairness? So the third and final recommendation that I wanted to review for you is the idea that we need to make vaccination available in safe, convenient, and familiar places. So once vaccines are available, there's going to be a massive scale up. The U.S. has never done vaccination quickly on this scale before. We had a slight run through with H1N1, but this is really a different situation. As part of this, safe and accessible vaccination sites that are both traditional and innovative are going to be critical. So something that's likely to happen, you're going to see the vaccines being offered at doctors' offices, at public health clinics, and other traditional sites. It's also possible, and we argue important, that innovative sites be considered as well, as the different vaccine technologies allow. So, for example, providing vaccines at senior centers, at workplaces, at places of worship, at WIC clinics, that all of those, it's possible that those will be included as well. And really, communications then with public health authorities, it's going to be very important as the vaccines are available at these different sites to provide up-to-date, comprehensible, and trustworthy information about vaccination opportunities. So what can be done? Once again, I'm throwing out an advocacy piece that we really do need to think about vaccination infrastructure and that this is available and safe, especially for poor and marginalized communities. You know, these sites need to be places that they can literally access in local communities. And local journalists are particularly primed to be able to ask the public and to understand where these sites may be. In addition, the vaccination sites really need to feel safe. And this is another role where journalists can play in speaking to members of the public. And then just an example for this, to explain what I mean, is that if, for example, you're dealing with a largely Hispanic community and the primary vaccination site is next to an ICE office, that may not feel safe for members of those communities. And so you may end up with lower vaccination rates because people feel that vaccination site is not a safe place for them to be, even if they want to be vaccinated. So we really need to start thinking about these types of issues. And then really, as journalists, providing up-to-date, detailed information about local vaccine availability is really critical. We saw this to some extent with H1N1. Where you had sites that were running out of vaccine, other sites where vaccine was still present, different formulations of the vaccine that were available at different areas. And this is something that the public is going to be clamoring for. They will definitely try going to the health departments for this information, but the more widely disseminated this information is, the better. And it's going to be very critical that whenever this is coming from non-public health websites, that the information is the same, so that every, for example, newspaper or news organization in local areas is providing the same type of information, so that there's not confusion about what's going on. So those were my points for today. That's the end of my slide, but I'm very excited to listen to your questions.
Thank you very much, both of you. That was a lot there. It's really cool. I don't know if Mr. Brunson, I mentioned this, but what you described regarding have a site right near an ICE office, near and a border patrol type office, or immigration office, excuse me. That actually happened, didn't it? Was it in Houston or San Marcos? It was San Antonio. I'm trying to remember where that actually happened. There was something similar to that, wasn't there?
I think it was in the Valley in Texas.
Okay. So I'm pointing that out to journalists because that's not a hypothetical. It's something that I think we as journalists need to be paying attention to in our communities and looking at where these sites are going to be and what feels safe and what doesn't. So we've had a couple questions come in, and I'll start on these. And please continue to send in questions as you have them. And I have lots of questions myself if we don't have more questions coming in. But one of the first questions we got in, and this is probably for Ruth, why do some mRNA vaccines require cold storage and others do not? And I'm going to add to that in why do some require extreme cold storage and why do some only require normal cold storage? And I'm thinking in terms of the Pfizer vaccine, I think it's, negative 94 degrees Celsius, whereas don't quote me on that. I know that the Moderna vaccine requires cold storage, but not nearly at that extreme level, something closer to what's more easily available in standard refrigeration. Could you just speak a little bit to that?
Yeah. So just briefly, as my understanding of this is that it's related to the lipid nanoparticle, the LNP. So the way all mRNA vaccines work is mRNA by itself is easily degraded, and it also has to get into the cell cytoplasm in order to be translated. So to do that, it's embedded within a carrier called a lipid nanoparticle that helps protect it from degradation and helps it traverse the cell membrane. And my understanding, as best I understand, is that the difference in thermostability for these two mRNA vaccines, at least, and perhaps others, has to do with the composition of their LNPs, which are proprietary unto the companies. I don't know what's in them, but my understanding is that's what makes the difference.
Thank you. That makes sense. I wondered that one myself. And Emily, a question about kind of what you've already been seeing. Have you noticed are there any things that you've seen in the media that are, I hate to use the word problematic, but just less helpful than they could be, even from well-intended media outlets or journalists? I mean, the reporting on the vaccine or on issues related to vaccine hesitancy that may be attempting to do good journalism, but there's something there that they could do better while still holding true to the principles of journalism. Yeah,
and I mean, and there's so much. But I think one of the big things that I'm seeing right now is that, and this is a double-edged sword, because you don't want to discourage anyone from being excited about vaccination, but the idea that it's going to be the silver bullet. And as soon as this vaccine comes out, that the pandemic's going to end. And, it's going to take time for vaccination to become widespread. If we can get to that herd immunity level, we're still going to need to be wearing masks. And I think it's important that the public understands that, this isn't going to change things overnight. And to sort of temper those expectations is going to be critical. We're excited. We want to be enthusiastic. This is some great news about vaccines being developed, but, it's not going to be the magic wand that's going to change things tomorrow.
When you say
actually, could I comment on that too? So I have a sort of a friendly amendment or a slight modification of that, and it actually has to do with hesitancy, and I completely agree that when we are first rolling out our vaccines and when we have limited doses available, that they're not going to be a silver bullet, because not everyone is going to be vaccinated, and as we discussed, we don't know the effect of these vaccines on transmission. But as vaccine is available, and certainly, I hope this will also be true globally, but in the U.S., we expect the predictions are, things don't always go exactly to plan, but people are really predicting into the summer, perhaps into the early fall, when we'll have enough vaccine for everybody. At that point, there's going to come a point when indeed it is the silver bullet. Indeed, it is the thing that will allow our society to get back to where it was. And I think that there will come a time when we may be able to say to the vaccine hesitant, you know what, we could open up our society but for you. If we can achieve herd immunity, we can go back to some semblance of where we were before the pandemic. So not a silver bullet today, and all of the very important warnings about public health measures are true, but I do, that's not an argument we've been able to use with vaccine hesitant populations before. And I think about whether that is an argument that may be compelling, also because by that time, we have a lot of data now. I mean, just to make the point that we don't usually have safety and efficacy data on 30,000 people or 45,000 people before we license a vaccine. This is an extraordinary amount of data, but we will have even more data than that at the time that we may be saying to some of those hesitant populations, really, it's your turn, and really it is time to step up and get vaccinated. So just a few additional thoughts.
Thank you for adding that. Yeah, the interplay between hesitancy and demand is going to be really interesting to see play out. And I think journalists need to be paying attention to the varying factors that affect both of those. A question, this might be a question for both of you, although Dr. Brunson mentioned it several times, the fact that we might still need to wear masks after the vaccine comes out. Is that because not everyone will be vaccinated and therefore we won't know who is and who isn't? Or is it because we don't know yet, and this kind of goes to whether or not the effectiveness is going to impact transmission, or whether it's just preventing the disease in the person? Or what are the reasons that we might continue to wear masks for some time after the vaccine has begun rolling out, or after a large number of people have been vaccinated?
So I think what Dr. Karen was just talking about is that, at first vaccine doses are going to be limited, that it's going to take some time before they're widely available. And so we're still going to have to keep all of the practices that we have to keep the virus under control. And really until you get to the point that you do have herd immunity, which functionally it seems like is really only possible through vaccination. In this case, that we're going to need to be protective of everyone, and it's complicated by the fact that the disease itself can be asymptomatic. So you could end up having people who don't look sick and don't feel sick that are spreading the virus. That's one of the reasons why we would need to keep on wearing masks just into the future for a while.
Anything you want to add to that, Dr. Karen?
Well, yeah, I mean, just to go back to the fact that we know that we have two vaccines that are highly, highly, highly effective at preventing disease. We don't know at all about their effectiveness in preventing transmission. So we hope they are that as well, but it's entirely possible that we could have that vaccinated people, if they don't continue to take these public health measures, could be asymptomatically infected and spread virus to to unvaccinated individuals who might become ill. So I think for all the reasons that Dr. Brunson said, these continuation of these public health measures is really important until through widespread vaccination of the population and herd immunity, that we've achieved a level of herd immunity that will be protective.
Another question about the cold storage is how realistic distribution of the extreme cold storage vaccines are. Is there infrastructure in place for the storage? And I think this is referring primarily right now to the Pfizer vaccine, because that's the one that requires the extreme. Is that a vaccine that we have infrastructure for cold storage vaccines that are necessary to distribute, but the ones that are more the extreme low levels of refrigeration that are needed, is that infrastructure in place, or can it be gotten in place quickly, or how realistic is that distribution looking? This is probably a Dr. Karen question. If you know, and if you don't know, then that's something.
Yeah, I would say that my understanding of what I've heard from Pfizer and from people in the public health sector is that work is being done to ensure that this vaccine can be distributed. I agree that it's certainly a challenge. It needs to be. It's going to be. I don't think the problem is going to be so much the shipment, because I think Pfizer has worked that out. I think the problem is, as you raised, Tara, is really going to be around the storage and the use. Not only that you're storing it, but when you open something up to take out the vaccine to use, are you maintaining temperature in whatever that container is? So I agree that it's a challenge. I think there are efforts in place, but I probably can't speak more specifically to that just because I'm not aware.
A question someone asked was whether the FDA has guidelines on how long placebo candidates should be followed. And I'm going to add to that by asking kind of more broadly, how long are study participants typically followed or likely to be followed post-licensure? So I know I'm thinking with the HPV vaccine, they still are following the participants who are in the initial study that led to the approval of the HPV vaccine. Is it an indefinite thing where they study them as long as there's funding, or how does that work?
I can speak to that if you'd like. So just a couple of things, and maybe also to lay out what the controversy is, what the issues are. The easy answer first to your question, Tara, is my understanding is that the current study protocols, and I think probably all of the colleagues here know this, but it's speaking of unprecedented things, it's unprecedented, but study protocols are available in the public domain. This doesn't usually happen. I think people, really ask for it in this context where a lot of public funds are going to fund these trials. Typically, that's something that companies keep private, and certainly at least until the time of licensure. So the answer to your question is in the public domain. But in general, for most of these trials, my understanding is the current plan is for 2-year follow-up. So the issue of how long should placebo recipients stay in trials, I think this is really a hot button issue. This is an issue that was discussed in depth at a recent VRBPAC meeting in October. I think the FDA's position is that it's important to have placebo recipients continue to be enrolled in the trial for as long as possible, and the position that they articulate is that there are things that we will learn about the duration of protection that we might only be able to learn in the context of having a placebo-controlled trial. I think there are a couple of ways to think about this problem and to separate out the categories. So one is, at the time that a company, and actually I should just back up for a second and say the FDA went one step further, which is they said that when companies apply for an EUA, they have to provide their specific plans for unblinding and what's going to happen with the placebo recipients. That actually needs to be part of their EUA application. So the issues can be broken down to what happens to placebo recipients at the time that their number is called in the community, so to speak. So let's say that you're a frontline healthcare worker and you've been in a vaccine trial, and the first vaccine is going to be rolled out for frontline healthcare workers. Most people would say that at that time, it's probably not ethical to ask people to remain unvaccinated at a time that your number comes up in society. But the question is, what about those people whose number didn't come up? You're lower on the priority list, and you might not get vaccinated till February or March or April. How do people think about keeping people as asking people really to stay on as placebo recipients for that interval? There are some mixed feelings about that. There are thoughts about innovative designs. For example, there's some discussion about whether there could be blinded crossover studies where that would be a situation where you still wouldn't tell anybody what they got, but you would, everyone who got vaccine would get placebo, everyone who got placebo would get vaccine, and what you could tell people is at the end of this X period, let's call it 2 months, everyone in the trial will have been vaccinated at some point. And then you could still do some things to look at, say, duration of protection. But I think it will be, for journalists, I think this will be a really interesting issue to follow, because I think we're going to hear a lot more about it.
Thank you for going into all of that. It's certainly a lot of interesting ethical issues. I think this is one of the vaccines where the bioethicist issues or bioethics issues are much more involved than we've seen in a lot of previous vaccine reporting. This is a question probably for Dr. Brunson, but I guess either one of you could weigh in. What are your thoughts on states' independent vaccine review processes? Is there some current concern that this will slow down distribution in the states? And I think what they're referring to are, if I'm correct, the states that have said that they there's been some, concern expressed about the process and whether, for example, the FDA process will be as independent and unaffected by politics as it's supposed to be. And some states have said, we're going to look at this vaccine on our own before we actually distribute it to our own citizens or residents, rather. And I don't know whether that will be different under a new administration in Washington, or whether they plan to keep that in place, or if that was specific to having one administration there. But could you speak at all to that?
So this is another aspect that's touched on in our reports that we actually advocate for, which are our public oversight committees of the vaccination process. That they're, and especially with the past political climate, that it was very important that you had perhaps more transparency about what's going on. And one way to accomplish that is to have state or even local level review boards where you're bringing in local experts, people who are not politically appointed, along with some community members for them to be able to review the evidence and to provide their own recommendations. We're also seeing this with different organizations as well. And forgive me, I'm not a morning person, and so this is completely escaping me what it is. But there is a medical group specifically for Black physicians, and they're also planning on doing the same thing. So, and to be able to use that to speak to Black communities across the country. So I think I see it, and especially in terms of coming from that more social position than necessarily public health one, that it could be an important mechanism to help build trust, and especially trust in more local areas in terms of what the vaccine is and what it's offering.
That makes a lot of sense. Anything you want to add to that, Dr. Karen?
No, I think that's perfect. Yeah.
A question about, and this is, I don't know, this is not necessarily within the expertise area of either of you, but if there's any speculation you're able to offer, how might the mRNA vaccines be useful to cancer researchers? And I think this is a question more of looking ahead beyond the pandemic. So many things are happening within vaccine research as a result of work on the COVID-19 vaccine, not just socially and in terms of infrastructure and distribution and those kinds of decisions, but just the science itself. If these two vaccines are authorized, they will be the first ever prophylactic mRNA vaccines ever developed, or any vaccines at all. Could these be used as either therapeutic or prophylactic cancer vaccines, or can the mRNA vaccines be used in some other way in cancer research?
Well, just to, I don't think I can comment on it extensively, but just to say that Moderna and I believe other mRNA vaccine companies, because there are a few of them out there, Moderna was working on cancer therapeutics with mRNA before they were working on vaccines. So that was the sort of, that was actually the beginning of some of the mRNA work. I think that work will continue and perhaps be strengthened by the spectacular results that we're seeing with these vaccines. As I understand it, there are modifications to the technology that you do when you want to give a cancer therapeutic versus a prophylactic vaccine. I will just say that Moderna also has, and again, other companies have actually worked on other vaccine targets, and I think this is certainly a validation of the mRNA technology in terms of prophylactic vaccines, and I expect that we will see the development of mRNA vaccines against other infectious targets, as well as work on cancer. So, and I can add nothing to that technological discussion, but I do want to address sort of that issue of having this current situation, really being a game changer in a number of different ways. And I think that, there's the potential, like you were just talking about, for some true technological innovations that we haven't seen before. But I just want to lay it out there that, we have the same potential socially for this situation, that we have the potential that if this is done well and right, that we can
strengthen not only our vaccination system, but also the way public health is done in the U.S. So this is really a golden opportunity to make some big improvements in our system. And at the same time, if this is done poorly, we run the risk of undermining public health generally, but what I'm really worried about is undermining our childhood vaccination program. That is critically important in the U.S. and right now there are issues, but it's fairly healthy. But if this isn't handled well, you run the risk of really undermining that. So this has the potential to be a fantastic opportunity, but it really needs to be done carefully. And so I think that's something for journalists to keep in mind when you are reporting. Is this something that is going to create a better future? Or is this something that is potentially undermining what we already have?
A question about special populations, those who are immunocompromised or are either because they have immunocompromising conditions or because they are on medications or cancer treatment regimens that compromise their immune systems, pregnant people. When can we, I know that Pfizer just started trials with 12-year-olds, so maybe children. When are we going to start to see vaccines available for those special populations?
So I think it's really important. I know that special populations is sometimes a regulatory term. I think it's really important that we don't lump them all together because I think they're really very, very different one from another. So let's take them sort of as they come. I'd like to first talk about immunocompromised populations and talk about the fact that we very well may have non-vaccine alternatives for those populations because it's entirely possible, not that I think these vaccines would be unsafe, but that I think it's quite possible that they wouldn't induce the kinds of immune responses that would be protective. So one possibility for those populations is long-acting monoclonal antibodies. As you know, there are two companies developing those, Lilly and Regeneron, and I think that those products are going to be, they're not useful when somebody's really sick, and I think those of us who understand something about respiratory virology are not entirely surprised by that. I think they're going to find their best use either prophylactically or very, very early in treatment. But I think those would be ideal populations to get these long-acting monoclonal antibodies. The other thing is there was a recent exciting development that some of you may have either written about or read about last week around nasal spray antiviral that's just been tested in animals so far, but that has the ability to prevent transmission in ferrets, which are highly an animal species that transmits really readily. Just to say that might also be, you could imagine if there's an outbreak, say in a nursing home setting, that might be a way to quell that outbreak pretty quickly. In terms of pregnant people, certainly I think there needs to be quite a bit more work done on that. That's something actually of great interest to me and something I've worked on along with my bioethics colleagues around access of pregnant women to vaccines in epidemic and pandemic situations. What I would say about this is I think it's really urgent that we develop data. We now know from the CDC that pregnant individuals are considered a high-risk population, and I think we need to figure out a way to safely vaccinate them. And I do believe that the CoVPN and Operation Warp Speed are moving forward, particularly with these very promising results to think about that. I think children present a separate set of considerations that also needs to be taken into account.
Somebody asked if there were good vaccine conspiracy or myth debunking websites and links. And this is probably more of a question for Dr. Brunson. I would add to that if you have any best practices to recommend on how journalists should address myths, misinformation, if there's anything that they should be particularly conscious about as they're trying to address misinformation, whether it's head-on or addressing a misconception that's already out there.
So I think that it's very important to go to the CDC website for information and to use that as a primary source. Dealing with misinformation is difficult, and I think that there's not an easy, quick fix answer, hence the reason why we have a problem with it. But I think in terms of reporting that when things are brought up that is misinformation, perhaps to not just dismiss it, but to include it, but then explain why that is incorrect and what the facts are. So, and there's been some really interesting misinformation coming out recently. Even with our report this week, there was a really big conspiracy theory around it, and so we did some fact checking with the AP and had to come out with statements for that. So it's something that I think it needs to be handled maybe a little bit more head on by journalists to really say, this is what people are saying, but these are the facts. But like I said, there's no perfect answer for this. It's a moving target. What's going to work, this month may not be what works in 3 months or 6 months.
Someone asked about whether challenge studies will be used to determine the effect of these vaccines in terms of asymptomatic individuals, and I'm going to reduce acquisition and viral load shedding. And I'm going to add to that another question that someone asked about whether whether we know the extent to which there will be a risk that vaccinated individuals could transmit the virus to unvaccinated people. So I think those are kind of related questions there.
Right. So I guess a couple of things to say about this. So I think the risk around transmission to unvaccinated people, I think we talked about that earlier, that we don't know. So what I would say is, and I think I've not made a secret of this, I have a number of concerns about human challenge studies, particularly since we don't know the full effects of this virus, even in young people, which is where the challenge has been proposed. We don't know all of the long-term effects we're learning. Those long-term effects are not completely restricted to elderly individuals. We also don't have, speaking of silver bullets for sure, we don't have an antiviral silver bullet right now where we know we can shut off replication. So I think these studies are highly risky. And so I think we come to a risk, and they're also in young people, so they don't necessarily tell us about what would happen in other populations that are not young people. So then I think we come to a risk benefit, and is the risk and a real risk to young individuals? Would it give us such a societal benefit that there might be a reason to consider this, from an ethical standpoint? And the question that I would pose back is, why is this critical to know? If we are planning for universal immunization, which is really what we're planning for, and it's just a matter of time, our plan is rollout, and our plan is to immunize everybody. Why is it that do we absolutely need to know whether this vaccine prevents transmission or not? Because ultimately the population will be vaccinated, and whether people are protected because there's less transmission or whether people are protected because they're directly vaccinated, one way or the other, they'll be protected. So I'm not certain that this is a question that needs to be answered at this point, given the risks of human challenge.
Makes a lot of sense. A couple of things to add here that people have mentioned. In the medical association you were attempting to think of that was for African American doctors was the National Medical Association. And someone also mentioned with regards to the extreme refrigeration issues that there was a piece on 60 Minutes a couple weeks ago with Military General Berna in charge of distribution who discussed that. So as more information for the other attendees here. And this question is also for, I think, Dr. Karen. There's been a lot of talk for years about a universal flu vaccine. And I know from your experience that flu and RSV are kind of your two specialties, including work on, looking at the universal flu vaccine. Is there any word on whether or not a broader coronavirus vaccine, is that even possible, or is it not? Like, can you just speak to whether that's a thing?
Well, I would just say, not to my knowledge, but the disease burden actually, if Dr. Hotez were here, he could probably speak to that. So I'm assuming that you're maybe not referring to the coronaviruses that cause mild colds, but you're talking about the more significant coronaviruses, SARS, MERS in particular, and whether we could have a joint MERS COVID-19 vaccine. That would definitely be a question for Dr. Hotez, because he's developing a vaccine that's based on cross-reactivity between those proteins. I think, there hasn't been a huge appetite for MERS vaccines just because the burden of disease on a global level, although for individuals, there's a huge burden in terms of a global level. There hasn't been a huge burden of disease, but I think it will be interesting to see what happens to MERS as COVID-19 vaccines are universally deployed. That will be an interesting thing to watch.
A general comment to the audience members. Dr. Peter Hotez was scheduled to join us today. He unfortunately was unable to join us last minute because of development in his lab related to the vaccine that his team is working on. So that's unfortunate, but we are going to try to see if it's possible to set up an additional Q&A type session or brief session with him separate from this at another time. So watch your email boxes for information on that if we are able to set that up. So sorry not to have him, but he's in high demand and it can be challenging. Another question regarding, this one's a question about herd immunity, and this is the kind of question I think is usually an epidemiology question for those especially who work in modeling. Do we know what percentage of people need to take a vaccine if we assume 90% effectiveness, as we're seeing with the two vaccines that we have the interim analyses on, to achieve herd immunity? Is that going to depend on location and the percentage of people in that locale who were already infected with the virus? So will it depend on past prevalence? And even with herd immunity, is there still some risk of infection for either the unvaccinated people or the 10% or so for whom it's not effective, even as we're approaching herd immunity? So kind of a complex question, but just can you help illuminate a bit about the interplay between what we know with vaccines in the 90-ish% range and herd immunity?
I assume for me, yeah. So,
I know how big a question that is. So
there's a lot to that, and maybe let me try to unpack that a little bit. And the first important thing that I really want to say is that I think that these vaccines will likely have durable protection against disease, and most especially severe disease. I personally, based on what I know about respiratory viruses, will be surprised if they have a durable effect on prevention of infection. We know for a lot of respiratory viruses that immunity is incomplete, but it protects against disease and especially severe disease. And I think that's fine, right? Especially if we have a completely vaccinated population and we have a little bit of transmission of virus and maybe people are asymptomatic or maybe people get colds, that's okay. We can certainly manage that easily as a society. So when we talk about herd immunity, just to be clear, I don't think we're talking about herd sterilizing immunity. I think we're talking about herd protection against disease. Then the question of how many people will need to be vaccinated to provide that protection against disease, we don't actually even know what we're getting some feeling of the R naught, and it's evolving a little bit for this virus, but what exactly that herd immunity threshold is. And, my guess would be, even though some of these vaccines induce levels of antibody that far exceed the immunity induced by natural infection, that probably for the most part, except in very rare circumstances, my guess is that natural infection will protect at least against severe disease if you've been infected once, unless you are, immunocompromised or otherwise not a normal host. In general, your next infection, you might be slightly symptomatic, but you're not so likely to be highly symptomatic. So my thought is, I think we'll have to just see what the threshold of herd immunity is that we need to achieve one way or another, either via vaccination or via natural infection. But just to be really clear, when we roll out these vaccines, we're not going to be testing anybody for antibody. That's not an efficient mechanism. You've been infected, you've not been infected, you're going to get vaccinated. And also, that's how these vaccine trials have been done, just to be clear. Certainly the phase 1 and 2, some of those were selective, but the phase 3 trials enrolled everybody, drew blood at the beginning, but enrolled everybody, and then we'll analyze the data based on whether you've had a prior COVID infection or not. So we'll just be vaccinating all comers.
I know what some people have been asking about how someone said, please explain scientifically why someone who is vaccinated and is protected from getting sick from the virus may be able to transmit it to others. Before we get to that question, which I think is one of those, it's kind of an explanatory question, a clarification for people who are unaware of this. There is a distinction between infection and disease. Infection is the ability of the virus to get into your body and actually start to replicate, and disease is the actual symptoms. So I think it's important that people understand the difference between those. Could you define quickly, Dr. Karen, the terms, you've used both of these terms, correlative protection and sterilizing immunity, for people who may be unfamiliar with those, and then address how someone who is personally protected from getting sick could still transmit it to others?
Okay. So we'll start with Actually, let's do sterilizing immunity, how it might help prevent or not infection to others, and then we'll get to correlative protection, which is a little bit of a related, but not directly related. So sterilizing immunity means that you prevent infection. And just to say that most of our vaccines actually don't do that. So flu vaccine doesn't 100% prevent infection. Rotavirus vaccine, we've pretty much gotten rid of rotavirus in this country. Rotavirus vaccine doesn't provide sterilizing immunity. So many of our vaccines that we consider highly effective vaccines don't 100% protect against infection. There are pathogens for which we really need sterilizing immunity, and the most obvious choice among those is HIV, right? We're still a long way away from an HIV vaccine, but the holy grail of that is to provide sterilizing immunity you need for people not to be infected. But for a respiratory virus, what you need is for people to not be symptomatic. And it is possible that people can shed some amount of virus for some period of time and not be symptomatic. And we know that for sure with COVID, right? Because we have all those, we know that people are often most infectious in that pre-symptomatic phase, right? When they are not, which is a unusual and really terrible for humanity feature of this virus, right? Which is that it's most infectious when people are least symptomatic. It was actually, interestingly, the exact opposite with SARS, with the first SARS. which is part of the reason that we think that we were able to contain it globally and why we didn't have a pandemic with the first SARS. So to that point, it would be possible that a vaccine would prevent disease, but wouldn't absolutely protect you from being infected. And if you were infected and you shed enough virus, you might be able to infect somebody you were in close contact with, even if you weren't symptomatic yourself. So I hope that's clear. That's the point about that. Then to get into correlative protection. So sometimes if you're lucky in trials, and it happens less often than you might think it should happen. But in a trial where, usually in these big efficacy trials, and this is true of all vaccine efficacy trials, not just for COVID-19, there are a lot of laboratory measurements that are done to look at B cell immunity, to look at T cell immunity, as well as looking at protection against disease. And so the hope often is that if you can find a laboratory measure, maybe it's an antibody level, maybe it's a T cell response, that correlates with protection against disease in future trials of similar vaccines, rather than having to go through a whole efficacy trial, which is, a big deal, as I think we all know, you could actually just look at the safety of the vaccine and the ability for it to induce that type of immunity, whatever it is. Let's say it's an antibody titer. Well, how many people achieve that antibody titer? And that's a much easier trial to do than an entire efficacy trial. The thing is that to be able to have a correlative protection, you need a threshold, and you need some vaccinees who are protected and some who are not. You need a spectrum. And the great thing about these vaccines in terms of the vaccines is they're highly protective. Both the Moderna and the Pfizer-BioNTech vaccine, it's greater than 90%. So in that setting, it's very difficult to find a correlative protection. I mean, all of us would take the efficacy over the correlate any day. I think we won't. I think there will be some effort to look, and certainly the laboratory assays have been done, but I think we statistically won't be able to find it.
Thank you. Lots of vaccinology 101 there. This is a question for Dr. Brunson. What kinds of factors influence people's trust in the vaccine process or vaccine decision-making, whether they're going to get the vaccine or not, and you address some things such as their, historical attitudes or, feelings related to the government and medical, the medical industry in general. But what are some other factors? And I'm thinking this question in terms of what can journalists be looking at to see where these factors stand, like whether they're being addressed or not being addressed, or digging into them a bit.
Yeah, and so this is an interesting question, because a lot of the understanding that we have about vaccine hesitancy is for parents in association with childhood vaccination, and so this is a different situation where we're arguing for vaccinating adults, and not older adults for shingles or flu, but the general adult population, and so they're going to be, the way that we think about hesitancy in this case is going to have to evolve, most likely. But definitely going into, people's past experience with vaccines and governance, public health governance more broadly, all of that can play a factor in how people are thinking and feeling about vaccines. How people understand that the vaccine has been produced is going to matter. How people feel that the vaccine is being distributed, and if that was fair and fair to people like them is going to be critical. So, there are reasons why we do vaccine allocation with new vaccines like this. It happened once again with H1N1, but people can misconstrue that and think that, I might be put back at the line because of these other factors. Or, if you put me first, like maybe you're trying to experiment on me. And you can literally have people in the same community that are going to feel, ironically, both ways about the situation. So it's going to be complicated. But I think what's important, and as journalists, thinking about what are people feeling, what are their hopes and fears in relation to COVID and COVID-19 vaccination, and what would really be the factors that would convince on personal levels people to take the vaccine, or even to be first in line. That these are questions that we can start asking and thinking about.
Great, thank you. A question about older populations. I think, Dr. Karen, you already addressed this briefly in saying that we don't know a lot about them. Do we know anything yet about how either of these vaccines might work in older populations, since they metabolize differently? Immunosenescence, the aging of the immune system, obviously, issue. And then mRNA vaccines have never been used before. Do we know much about even what kinds of vaccines tend to elicit stronger immune system responses in older populations?
So in the press release from Moderna, what they said was that they observed efficacy across the entire spectrum of enrolled vaccinees. So they did enroll individuals over 65 and under 65. And I believe they specifically called out protection in older individuals. I think, we'll have to wait and see the data to get more specifics on that. But the initial comment from Moderna was that this appeared to work in older individuals as well.
Returning back to the silver bullet question of whether or not a vaccine could be a silver bullet, there's sort of the two different narratives here that both of you addressed, which is one being a vaccine's not going to be a silver bullet, at least not initially, but it will be eventually, and we have to worry about vaccine hesitancy. How do journalists balance those right now? The tempering of expectations without discouraging, without increasing hesitancy, but also being conscientious about the reality of hesitancy. It's a weird balance to try and strike as journalists when your work will influence, public readings of these things.
Very careful writing.
Can you expand on that?
Well, I think like you said, there are some competing issues going on here where you don't want to discourage people, but you need to be transparent and transparent about some things that they may not like to hear. And, and there's the potential that, all of this can feed into existing anxieties that people have. And so I think maybe one of the ways to address this is to not focus on writing one-off pieces, but to be following the issue and to be revisiting the issue on maybe even a regular basis, so that you're talking to people, you're, finding out what their concerns are. You write another article that's really specifically addressing those concerns, and that you're playing the long game. So it's not like I'm just going to get my one piece off and through, but in terms of the portfolio that's going to exist with this topic and this issue, to think about things in long term and be willing to take that type of an approach.
Following up on that, earlier, when I don't remember which of you, but we were talking about getting back to some semblance of where we were before the silver bullet. Given health disparities and the huge impacts on racial and ethnic communities, do we want to talk about things in terms of getting back to normal? And I think seeing whether a lot of things can be improved. Should we be using different language instead of getting back to normal, something that implies something that doesn't necessarily imply the kind of normal that wasn't great for other people before this begun? What are ways to think about how we talk about that?
So I think one thing to think about is to put this in local, meaningful terms. That when you talk to people, that it's not necessarily normal that they want to get back to, but they very much want to be able to spend time with their extended family. that they want to be able to go back to church, that, they really want to be able to go to the movie theaters again. And so I think in terms especially on a local level, it's finding out, what are the things that people want to get back to, and then framing it that way. So it's not necessarily back to normal, which, as you said, is good for some people and not for others, but really, what is it that we can get back to that's of interest and of importance to you and to different communities?
So not speaking like in terms of normal or broad terms, but speaking in terms of specifics, like this is when you get to go back to the movies, this is when your kids get to go back to school and so forth.
Yeah, and to really, tailor this a little bit locally for what's important to different communities, because it's not the same thing. You can definitely argue the church piece if you're in the South. If you're in the Northwest, that's probably not going to be the argument that you'd want to make. So it's but thinking like, what is it that people really want back in their lives, and framing vaccination is the way that this can happen.
You say that, I think back to the very, very early days when South by Southwest was the first really major, huge event to be canceled as a result of concerns about the pandemic in Austin. I think in Austin it might be when you can go to a live music show again, or when half of this city can be reemployed by Southwest again. So that makes a lot of sense, especially in terms of local businesses and the local economy. Can we return again to the mask question? I think there was a little bit of confusion when we were discussing that before. So if you've been vaccinated, you would or would not need to wear a mask? And would only unvaccinated people need to wear a mask until widespread vaccination occurs? And I know we've addressed this a couple times in different ways, and we've talked about the sterilizing immunity versus the ability to transmit even after we've been, but I think there's still some confusion out there. So even if you might be repeating yourself, could you go over that again, Dr. Karen?
Yes. If you've been vaccinated, wear a mask. You still have to wear a mask. You still have to wash your hands. You still have to maintain 6-foot distances. You still have to do all the things that you did before. How about that?
That works. A question about the timetable for the rollout of the vaccines and the pecking order for how those in different risk demographics will be served, and then others regionally and nationally. I know that the National Academies has put out a paper on this. Can you discuss, and this is probably a question for both of you, I think I expect both of you have looked at this in different ways, who will be likely to get it first, second, third, like what the priority are and what the reasoning is behind those priority determinations? Dr. Karen, do you want to start?
So I think, so just to be clear, the prioritization will also happen at the local level. I mean, there's been guidance from the National Academies, there will be guidance from the CDC, but ultimately every state is developing its own plan to prioritize. And I think in general, the way this will start is healthcare workers who are on the front lines, who are at risk based on their work and their exposure. So, for example, a psychiatrist who is conducting their entire practice online at this point is a healthcare worker, but they would not be considered a frontline healthcare worker because their risk of exposure either of themselves or of their patients is not related to their professional work. So frontline healthcare workers, other frontline workers, firefighters, EMTs, people who work in essential services like grocery stores, those sorts of things. Those are all frontline workers. Individuals with underlying health conditions and the elderly over 65. I think those are healthcare workers first, and then those other priority groups in rapid succession, and then other adults, and then on from there. And in some cases, so the other thing is, in terms of getting schools open, there have been some plans, and not all plans, that have prioritized teachers, because the theory behind that is the teachers that in a school setting, and at some point talking about schools isn't necessarily a topic specifically related to COVID vaccines. There have not been a lot of school transmissions, particularly at the elementary school level. And obviously there are great risks to children of not being in school, probably beyond the scope of this discussion. One thought has been if you, for example, vaccinated elementary school teachers, the risk to young children of severe COVID disease is low. You wouldn't necessarily have to vaccinate all elementary school children. You could potentially vaccinate the teachers. Does raise issues about could children get infected and bring it home to their families, which is another separate consideration. So in some scenarios, and I believe in the National Academy scenario, teachers and individuals like that are ahead in the prioritization order of the general adult population.
Thank you. A reminder to everybody that we have about 5 minutes left, although you will have an opportunity to ask additional questions once we do the breakout rooms and the Zoom sessions. But if you do have any additional questions, please go ahead and send those through. Dr. Brunson, anything to add to that about regarding the pecking order, if you will?
No, I think Dr. Karen covered that very well.
Okay, great. There was earlier a discussion about the need to use non-traditional sites for distribution. And I'm just going to read this question out loud because it's quite lengthy, and we've discussed the logistics a bit, but in case there's anything that can be added here. The logistics of vaccine delivery are daunting, and I will add my, to say the least, to that. It's huge. The need to connect with the state's immunization registries to track doses and adverse events, the need to return at precise intervals for second doses, keeping the vaccine cold or ultra cold. How do these logistic challenges make the broad non-traditional delivery more difficult or even impossible? When even traditional use will be difficult, and then we look at non-traditional sites, what are we looking at there?
I know, and it is complicated. I mean, and part of this though too is you have to think that we really do have to scale up to be able to manage a mass vaccination in the U.S. So we're going to have to increase capacity, and then the question becomes where and how. But definitely all of this is going to be complicated. And so with the vaccine that requires it to be maintained at minus 70 degrees Celsius, that isn't going to be, a vaccine that you could, for example, administer just at the grocery store. That's much more complicated. So we're looking for additional vaccines to come out that are more user-friendly in terms of, vaccinating in different situations. But it's something that we need to keep at the forefront of our minds in terms of access and especially equity, that we really need to be thinking about things, in terms of, are there situations and is the way this is set up going to keep people from being vaccinated and people who are at high risk for the disease because of the jobs that they're working, the living situations that they're in. So it's something that we need to be really considering moving forward and thoughtfully, knowing that, there may be some big limitations that may prevent that type of an ideal widespread rollout.
Is there anything you want to add to that, Dr. Karen?
I don't think so. Thanks.
When you were talking about alternate sites, it reminded me once upon a time when I was allowed to fly in the airport and not get sick, that I was walking through O'Hare one time and I was asked whether I wanted a flu shot. And I was kind of thrilled. I was like, this is so cool. Some local hospital is up here giving out flu shots in the airport. And then that made me think whether there will ever be a mandate for customers of flights have to be vaccinated. I saw something from Ticketmaster recently where they were talking about how they will check on vaccination among people who want to go to concerts. Can either of you, and this is probably more in Dr. Brunson's area, speak to whether we're going to expect to see any kind of mandates, whether it's for employees or for customers, and how is that even logistically possible? Is that wise? And I realize I'm asking this question with like 2 minutes to go, so let's open a bioethics can of worms here. But do you think there's a lot of mandates like that, or is that even wise?
It has been done in the past. And it's been supported with the Supreme Court with smallpox vaccination back in the early 1900s. We use school right now for children because there's a gateway to be able to check the vaccination. There's no mechanism besides lining everyone up, literally to check with adult vaccination. So I don't think, and I wouldn't advocate for mandated vaccination. I think that we might see it in some instances with employers, and especially when it comes to healthcare workers, that there might be hospitals that will insist. The military may insist. You may end up with some universities who will also insist. But really for adults, vaccination, those are almost the only mechanisms in place to actually enforce any type of, vaccination. It's going to be better to, because nobody likes getting told what to do, if people make this choice on their own.
A question also for Dr. Brunson. What do you think will be the primary reason for vaccine hesitancy? What are people most worried about?
Right now, and I'm collecting some data on this myself at the moment among college students, I think people are concerned about the timing of the vaccine. This was also a common concern with H1N1, that it's rushed, that it's somehow unsafe. And so I'm talking to a lot of students who are mostly willing to take it, but they want to wait and see what happens to the first set of people who do take it. So I think that's going to be the big issue is the speed in which the vaccine was developed and how that is interpreted.
Thank you very much. I think that's a good place to end. Thank you both very much. We covered a lot of ground today, and I expect there may be some follow-up questions. So thank you, everybody, for joining us. As we sign off here, keep in mind that there will be breakout rooms available for you to pester these two incredible women with more questions. Thank you very much, everybody.